So thanks again for joining us this evening. I want to just go over quickly the agenda. I'm going to do a brief introduction here and then get out of the way and let the professionals take over. Dr. Radcliffe is going to talk about some problems with our old friend, the Goldmann tonometer. And then Sean McCafferty is going to talk about the design of this new CATS Prism and how it's been validated. And Dr. Radcliffe will come back on to talk about evidence in the literature validating the CATS Prism. And Paul Karpecki will join us at the end to do some case presentations and talk about using the CATS Prism in clinical practice. Just a few housekeeping items on the probably right side of your screen. There's some handouts that you can download, probably some brochures and frequently asked questions and other useful documents that you can download, PDFs and things. We will do, I believe, 4 audience polls during the webinar tonight, so that's the fun and interactive part of the evening. You get to vote, and we see how things shake out. If you want to ask a question, you can use the type in a question function on your GoToWebinar control panel. I'd like to do that rather than opening up the microphones. It can get a bit chaotic with hundreds of people on the line. And then after the webinar, you will receive an email from us with a very brief survey in it. We ask you to please take that survey, let us know how we did so we can do a better job next time. With that, I want to introduce our speakers this evening. First of all, we have Nathan Radcliffe, MD. Nate is regarded globally as an opinion leader in glaucoma. He's published dozens of peer-reviewed papers, and he's always on the podium or the webinar these days, educating his peers and colleagues about glaucoma. He is at the New York Eye and Ear Infirmary and the New York Eye Surgery Center. Sean McCafferty, ophthalmologist and inventor of the CATS Tonometer Prism, also has degrees in mechanical and optical engineering. Sean's one of those guys that makes me feel really lazy, and is the founder of Arizona Eye Consultants. And then Paul Karpecki, optometrist, clinical director of cornea and external disease at Kentucky Eye Institute, associate professor at Kentucky College of Optometry, and Paul is a consummate author, speaker, and educator. I'm sure you've seen him on the podium and on the webinar a lot these days as well. So those are our speakers, great group of guys we have on for you this evening. And right now, I want to turn it over to Nate Radcliffe to talk about basically why we're here. Dr. Radcliffe.
Sure. So first of all, it's great to be here. And for those of you who tuned in, thanks for listening. You know, corneal biomechanics, corneal thickness, IOP measurement, glaucoma, are all kind of, to me, exciting topics, you know, and hopefully you'll feel the same way as you listen in. You know, if we take a look at Goldmann tonometry, there are a few things on our slit lamp that are a little old, but tonometry, the inventor of Goldmann applanation tonometry, Hans Goldmann, was born in 1899. I mean, that's a miracle. And it's a miracle that that technology has made it into this era. And actually, Dr. Goldmann himself made it till to 1991. So there's some good longevity. And of course, we're grateful for those contributions. But technology should evolve. And, you know, have in the field of glaucoma come to appreciate the importance of some interesting things about the cornea. Its geometry, its thickness, of course, became really important when its role in first ocular hypertension and then eventually glaucoma were recognized, with a thin cornea serving as both a correction factor for Goldmann applanation tonometry, as well as an independent risk factor for the development and progression of glaucoma, validated now in many studies. And yes, if you have a thin cornea, you're a glaucoma suspect. But beyond that, corneal biomechanics in the field of corneal hysteresis have grown equally, in part with the ocular response analyzer from Reichert and David Luce's contributions. And we recognize probably an equally exciting aspect of corneal biomechanics, risk, and pressure correction from corneal hysteresis. And even very interestingly, hysteresis and corneal thickness are not the same thing. So Sean McCafferty, an engineer, as you heard earlier, and ophthalmologist, really just had a very simple, but I think brilliant idea, which is to revisit the tonometer tip on the Goldmann applanation tonometer and see if it could be re-engineered to get a more accurate pressure and one that does a better job of cutting past corneal thickness and biomechanics. And all these things come together today with these new opportunities to get the best pressure measurements and get the best information to allow us to give great care to glaucoma patients. And with that, I look forward to tonight, and Sean, look forward to hearing you explain how you came to do what you did.
Thanks for that intro, Nate. I'm going to do the first poll question here before Dr. McCafferty takes over. So everybody should see the question on their screen. Do you use Goldmann tonometry as your primary method of tonometry? So hopefully the audience members are seeing that and voting on it. And here come the votes. And so right now it is heavily Goldmann. Yes, 81% use Goldmann as the primary method of tonometry, bumping back and forth in the high 70s, low 80s. So that's not a surprise. As Dr. Radcliffe mentioned, Goldmann's been around a long time, considered standard of care, and it looks like the vast majority of people are using it as their primary method of tonometry. I'm going to make the poll disappear there, and I'm going to turn this over to Dr. McCafferty, who is having trouble with his webcam, so you're just going to have to hear him and watch the slides.
Yeah, I apologize. I am here. I'm actually all dressed up and with a suit and a tie, and but nobody gets to see that today. Anyway, you can move on there to the next slide unless you had another question on there. I think that all of us are familiar with the Imbert-Fick principle, and Imbert-Fick both independently came up with the idea that if you press on any pressurized sphere and you apply a certain amount of force over a certain amount of area, that you can determine what the pressure is inside that pressure vessel. And that's what Hans Goldmann had expounded upon in being able to measure pressure on the inside of the eye. The variations, of course, and if you read Dr. Goldmann's original paper, it's actually fascinating the way he came up with it. He actually looked at various applanation areas and what would maximize his ability to be able to measure what the true intraocular pressure is. And that's how he came up with that area close to 3.06. He looked at something a little bit smaller and something a little bit bigger. But one of the things that he also understood, even at that point in time, is that there were variations in corneal stiffness, rigidity. There were variations in individuals' corneal thickness and corneal curvature. And there was even a tear film, which he hypothesized would negate most of these corneal rigidity errors that we were seeing, which were adding force to the tonometer surface. And that's how he came up with this area, and it also turns out to be a nice even number when you look at the actual area of 3.06 millimeters. You can move on to the next slide there. But the significant errors that he recognized and that we all recognized are due to patient variability. In other words, not everybody is the same. You have people that have very thin corneas, very thick corneas, and that's the one that most people understand and know. As a matter of fact, about 30%, or strike that, 50% of the patients will have just in corneal thickness error, enough of a corneal thickness variation so that they can be greater than plus or minus 2 millimeters of mercury in error from true intracameral pressure. And that's what really has come back to our original nomograms that over the last about 20 years ago, we started using them to be able to correct for intraocular pressure, but that has not been a good practice because there's so many other factors that are involved. You can go on to the next slide from there.
Well, there's one more poll we're going to ask the audience here out of our 4 polls this evening. So the second one is, do you believe that Goldmann tonometry is affected by corneal thickness and biomechanics and factors of this nature? Well, good, 100% yes. That's great news. Great news to hear that everybody understands that these days. Okay, so I'm going to close that poll and move on to your next slide here, Sean.
And there are a couple of studies that looked at one, I believe, Journal of Glaucoma. The other one was the British Journal of Ophthalmology, which looked at the central corneal thickness and whether this was able to predict which direction things were going to go. And in general, we know that a thin cornea has a higher risk of glaucoma, and a thicker cornea typically is a little bit safer. But because of the other factors that are involved, and that being mainly the corneal rigidity, that we can actually end up going the wrong direction with this. In other words, we can have somebody with a thin cornea that we suspect is going to continue to progress. but in fact, they do not. As a matter of fact, they may even find that due to other factors, and that may be mainly the rigidity of the cornea, that we may be treating them in the wrong direction or over-treating them in that case. And I think you have a few little references down there at the bottom too as well. And I think most of us, I don't know if all of us, but I think many of us recognize that this is not a good correction at this point in time, just to correct the intraocular pressure for CCT because of these other factors that are involved. So from that, what we decided to do, and this comes back to some of my original work in LASIK, where we were looking at the corneal biomechanical effects with Dr. Cynthia Roberts. We originally developed a lamellar finite element analysis model, and we brought this out of the mothballs and redid it so that we could actually look at what the forces are and what the problems are that occur with applanation tonometry, and a way to be able to improve upon them. In both of these, you saw originally the flat surface, which applanated the surface, and then we initially came up with more of a spherical surface, which reduced the error significantly, but we thought that we possibly could go even further than that in optimizing this. You can go on to the next slide there. So what we found is that the intracorneal stress, in other words, that stress concentration that occurs during applanation, is what gives force to the tonometer surface, which is not due to intraocular pressure. In other words, the error that we see. And that was the key to the optimization. If you look at the slide or the graph there on the right, that red peak is actually the intracorneal stress that occurs in flat applanation tonometry. And some of our optimized surfaces that we had come up with, mainly the purple one down there in the bottom, those were able to minimize that intracorneal stress and thereby minimize the amount of force that is pushing back on the tonometer surface while you're applanating, giving you that error. And if you look over on the left, I mean, it basically shows the difference between the two. We're looking at a flat surface versus a concave convex surface. Now, it still applanates, but it applanates to a very slight degree, is what it does, and there's very little displacement of the fluid in the anterior chamber. It's about a fraction of what the normal displacement is that you have in a flat applanation tonometer. You can go on to the next slide. So what we're able to find, and this really is one of the key findings, is that with this optimized design, and this optimized design, what we did is we took a probability distribution of people's corneal thickness, people's corneal rigidity, and their corneal curvature, and we put them all into a computer to be able to run a iterative program to be able to design this curved surface so that it minimized simultaneously all three of those probability distributions. And what we're showing right here is that with this, we're able to reduce the intraocular pressure area in about 98% of the patients from plus or minus 6 millimeters of mercury down to plus or minus 2 millimeters of mercury, just looking at the corneal rigidity. You can move on to the next slide. In addition to that, we also looked and wanted to address the tear film. This is something that's been long ignored in anything that contacts the eye, and it's something that is a very prominent problem, and we'll go over that very shortly as well. But we wanted to minimize as well the corneal adhesion force that you get on the surface, which pulls the tonometer away from the eye, actually reducing the pressure contribution, which were thought, again, to negate each other, but in fact don't. What you can see there on the left is the legacy prism, and on the right is the CATS Tonometer Prism with its concave convex surface. But in addition to that, there are several other features, and this was kind of a wish list from our glaucoma specialists here at Arizona Eye Consultants. They wanted something that could fit between narrow palpebral fissures, so we reduced the applanation diameter of that surface down to close to 6 millimeters, which really makes a huge difference in trying to be able to work with some of the patients who are squinting, etc. In addition, we also created an intuitive finger thumb hold where you can take this on and off for cleaning and disinfection, and works well for a disposable version as well. And lastly, we designed this so that it's very robust. These are now laser welded. We have you can see that scalloped flange on the back. There's a lot of surface area on that back plate, so that these things can be dropped and manhandled pretty significantly and be able to survive for a considerable amount of time. Then what we wanted to do is be able to prove this. So we had all of this theory, and we wanted to be able to show that CATS did show an improvement in being able to measure the intraocular pressure. Therefore, we can't just measure directly to GAT, because who actually is more correct? So therefore, we had to go to measuring a true intracameral standard, putting a pressure transducer directly inside a live human eye. I can tell you that personally it was a harrowing study that I never want to repeat again, but we did actually measure the intraocular pressure on 58 eyes undergoing cataract surgery. What we did is we placed a pressure transducer a few centimeters off to the side at the same height as the anterior chamber. Then we used a bottle height to modulate that pressure from 10 to 20 to 40 millimeters of mercury successively. And then we looked externally by measuring with an applanation tonometer the difference between CATS and GAT, and looked at the difference from true intracameral pressure. Simultaneously, preoperatively, we looked at central corneal thickness and corneal hysteresis, which were easy to measure. What we found were some surprising things, but really, if you look back through the literature, they're not that surprising, in that GAT does have a significant bias. In other words, the Goldmann applanation tonometer measures about 5 millimeters of mercury lower than what the true intracameral pressure is. And there's probably about 8 intracameral studies. I could only find 2 additional studies that actually modulated the pressure on the inside of the eye. Most of those were able to find is that there was a significant underestimation of what the true intracameral pressure is by Goldmann. In our original design, of course, we could measure what the true intracameral pressure is, but that was one of the design features, is we wanted everybody to have the same standards previous on your Goldmann as you would have on the CATS tonometer. Therefore, what we did is we introduced this bias back into the design, which allows a 16 to be a 16 and not a 21. So a new normal pressure would be 21 if we were to actually measure what the true intracameral pressure is. These are what our findings are. We found that there is a #1 bias in both of them, which is what we designed and what we expected. In addition to that, there is a sensitivity, and you can see the red line is a sensitivity to central corneal thickness in the Goldmann applanation tonometer, which is statistically significant. In addition to that, we also found that the CATS tonometer did not have this dependence on central corneal thickness. We had no way of really measuring corneal rigidity other than corneal hysteresis, which there's sort of an indirect correlation in between those, but we found this exact same finding. If you look over onto the slide over there on the right, we also found a significantly improved correlation to the true intracameral pressure in thin corneas with the CATS prism versus the GAT prism. Next slide. So our conclusions, we found again that there was a significant underestimation in Goldmann, and the Goldmann underestimation was greater in the supine position, and that's mainly due to the weight of the corneal button and measuring straight down from the top. There's also a significant GAT correlation to central corneal thickness in vivo, which is not found in the CATS. We do not have any significant correlation to central corneal thickness. And we also found that same thing with the corneal hysteresis. Next paragraph, next slide. In addition to that, something that's been long ignored is the problem of tear film error. There are 2 studies that were able to find out there which estimated what the tear film error between 3 and 4 millimeters of mercury. What we did is we wanted to find out, A, what is that tear film error? Can we actually measure it? And B, what is our effect by curving this surface away from the cornea in the area where the tear meniscus is? What we found is that our model that we produced for this, looking at the hydrostatic forces that occur, we greatly reduce the adhesion force if we pull that surface away from the cornea, such as shown here in the video. And this reduces the amount of adhesion force that you have pulling the tonometer forward onto the cornea. Next slide. So then again, we wanted to go in and actually measure this. We took cadaver eyes and we subsequently measured the pressure inside the eye intercamerally and brought that back to, we extrapolated that back to 0 over several pressure measurements, and looked at the separation force that you get from the tonometer as you pull it away from the eye. And if you click on the next click down there, we're able to find that about 4.5 millimeters of mercury is what the adhesion force in general of a Goldmann applanation tonometer prism is reduced by about 41% down to 2.7 millimeters of mercury with our flange design that pulls away from the outer portion of the cornea on that peripheral area. Next slide. So in summary, the CATS Tonometer Prism design, it has met the design objectives to reduce intraocular pressure measurement error related to central corneal thickness, the corneal biomechanics, including corneal rigidity, and tear film. Also, according to our design, we've matched the traditional Goldmann applanation tonometry on average. In other words, so for somebody that has a 550 micron cornea with a nominal corneal rigidity, both the CATS and GAT are going to measure equivocally. But we have substantially less artifact due to these corneal biomechanical errors and tear film errors. But we still can maintain the long-standing benchmarks of 16 plus being a normal and 21 being a high intraocular pressure. Next slide. I believe you're up, Nathan, unless anybody had any questions in the interim.
I'm keeping tabs on the questions. We don't have any yet, but when they start rolling in, I will direct them to the appropriate panelist.
So Sean, I'll make a couple comments just as we get started. And one is that the body of work you just presented was phenomenal. And I remember we were at ASCRS one year and you presented your manometry data and won best paper session. So, that was great. But, just the amount of work and perseverance that went into this study, just from a purely research standpoint, and as I know you're a busy clinician, so that's commendable just before we get into the applications.
Well, thank you. I mean, I definitely appreciate that. And yeah, there was a lot of work that went into it, but I do love this. I mean, this is something that I truly enjoy doing.
And then next, I'll say that as I present, some of your clinical studies here, keep your mic on and don't be afraid to, highlight anything I missed. Because you've been there for every step of the way with this. Just a little word about tonometry values. The typical intraocular pressure is 15 millimeters of mercury. Standard deviation is 3 millimeters of mercury. And we usually say 21 is considered high, 2 standard deviations above the mean, and 9 or below is low. And so that describes the norm of normal eyes. I think one of the important things here is that, if you think about cranking the pressure in your tires up to 35 PSI, 15 millimeters of mercury is equivalent to 0.29 PSI. So it's a small amount of pressure that we're looking for in the eye. And when you think about a drop that's going to reduce the pressure from 19 to 15, taking someone from the high teens to your target in the mid-teens, you are truly looking for a needle in the haystack. And that's why these seemingly trivial variables like corneal thickness, hysteresis can have such a big impact on pressure measurements. And it's because we're really looking for very small differences. That nerve apparently is extremely sensitive to very small pressure changes. And so, we find ourselves in a difficult position. Sean, you pointed out that GAT doesn't really give us the actual intraocular pressure today. But since every clinical study that's been done, OATS, SIGITs, AGIS, everything we know about glaucoma is based on GATs, we have to stick with that standard. And so Goldmann is still the standard and CATS won't change that. In fact, CATS supports that standard. And all tonometers are calibrated to match GATs. So what we are looking for is a tonometer that on average gives us numbers that if the corneas were normal and had normal values like normal thickness, normal hysteresis, would give us the same number as GAT. but a tonometer that's a little bit smarter when it comes to an eye with a high or low thickness or hysteresis. And so CATS, it's important for CATS to match GATS. And let's take a look here. So it's been designed to match, and you know, CATS will read higher or lower than traditional GAT in eyes that have properties that deviate. So you know, we're looking, what you'll see this come up commonly, CATS minus GAT. This is the intraocular pressure measured with a CATS tonometer minus the intraocular pressure in that same eye measured with Goldmann applanation tonometry. And when that number is positive, when it's say 4, that means that you, with GAT, would have underestimated the pressure by 4 millimeters of mercury. And we don't want to do that in glaucoma. And when will we do that? Well, in eyes with very thin corneas and eyes with low hysteresis. And underestimating might lead us to undertreat. It might lead us to not have a good assessment of how well our drops are working. So ultimately, if you switch today to CATS, and I think Paul will probably talk about this experience, on average, you'll get the same accuracy, but you'll have better confidence that in an individual eye, you aren't being thrown astray by corneal properties. And so with that, this is the study that supports the FDA clearance for CATS tonometer, intraocular pressure measurement accuracy and repeatability of the modified Goldmann or CATS tonometer. And these are patients who had measurements with both devices and also had thickness and hysteresis. So you're looking at a few things here. The Bland-Altman plot here is what you need to do to correlate to the ANSI standards. And you also, you know, you want to stay within that range you see outlined by the 2 dots in order to say that you can accurately represent GAT with the new tonometer, the CATS tonometer. And then we also looked at some box plots of folks, different operators measuring with different, you know, different slit lamps, just to show that we don't have any operator dependency for this new tonometer. And I hope we'll talk a little bit about how to measure pressure with it later, but it's really the same technique with just a few things that are actually kind of nice about it. So then you're going to see is in the first plot here in blue, a correlation between CATS and GAT for average IOP measurements. And it's really important to show that CATS and GATs have good agreement and good enough agreement so that they can be interchangeable for your patients on average. But what really is important are the next 2 plots, looking at corneal hysteresis and corneal thickness. And what you basically see is that there will be a positive CATS minus GAT number in eyes with a lower hysteresis, and there will be a positive CATS minus GAT number in eyes with a thinner cornea, and that there is a linear relationship for both of those as you move from thin to thick cornea, low to high hysteresis. And what that is really telling you, because we already know that Goldmann applanation tonometry, for example, overestimates pressures in a thick cornea or high hysteresis. So we don't need to reprove that with this study. We just are showing here that the CATS is less influenced by those properties, right? If your tonometer really was capable of measuring like a manometer, the real IOP, you shouldn't see any dependence of corneal properties that aren't related to pressure. And so this is, you know, this comes up my favorite joke, and you don't hear too many tonometry jokes. So, you know, just hang on to your seats. But, you know, ask people what their favorite pachymeter is. And, you know, I'll sometimes say it's Goldmann applanation tonometry because I've measured corneal thickness with that thing more times than I'd care to. Because whether you want to or not, when you measure the pressure, you're getting some thickness information scrambled in there. And CATS allows you to get more of the pressure, pure pressure information with less influence or dependence on the hysteresis and thickness. So we're looking at a substantially equivalent on average, and as I said, less dependence on hysteresis and corneal thickness, and that's the goal of the CATS tonometer as well as the other properties. If you start using this in your practice, you shouldn't see any real difference for patients with no pathology, no glaucoma, but you will notice again that positive CATS minus GAT type of difference, and in patients with glaucoma suspect, ocular hypertension and glaucoma, And, you know, I'll say anecdotally, my first day using CATS, I had a lot of patients who would always, you know, something wasn't making sense about their care. And then I started getting the CATS measurements, and it fit a lot better with their scenario, whether they were someone who was not stable or someone who was more stable than their pressures would suggest. When you look at eyes with progressive open-angle glaucoma, that difference is going to be bigger. And again, makes sense. Those are the eyes with thinner corneas, lower hysteresis, higher risk, more likely to progress. And note, this is a big study, 323 patients. But those with stable glaucoma, yes, you're probably still with Goldmann underestimating their pressure, but just not as much as if they're the ones who are progressing. So again, it's giving you useful information, and then you can have more confidence that the pressure number you get is something you can act upon, rather than having a pressure number that you get and say, well, I don't know if I should follow this because of the patient's cornea. Not surprisingly, we know that we are underestimating IOP in eyes that have had LASIK, and we can see that better. So CATS would give us a more accurate assessment of intraocular pressure, less dependent on that thin cornea, low hysteresis in LASIK patients. And then, so then it leads you to ask the question, well, what else is kind of, you know, affecting the care I give? And the pressure change from eye drops is something that we don't think too much about, but if the Goldmann tonometer isn't accurate for measuring one pressure, why should it be great at measuring a pressure change? And so this clever study here, again, that was conceived by Sean, looked at 36 treatment-naive glaucoma patients, 72 eyes, randomized, treated with latanoprost or timolol, and measured with CATS and GAT. Hysteresis and corneal thickness were measured, and, you know, looking at people who respond with a 20% pressure reduction from baseline. We had hypothesized earlier that perhaps corneal properties like a high hysteresis were part of the reason we don't see a good responder rate sometimes. Maybe it's not the drug isn't working, maybe it's the cornea won't tell us the secret inside that eye. And you know, what we see here is greater latanoprost pressure reduction was measured with CATS and then with GAT. And the reason for that is that latanoprost tends to increase the hysteresis a little bit. So you're getting a change in pressure, but also a change in hysteresis. You know, remember, hysteresis is dynamic. It changes from one pressure measurement to the next, and it changes a little bit when the pressure changes. And what was happening with GAT is that you couldn't measure pressure reductions, and you end up seeing a higher rate of non-responders in eyes measured with GAT. When you measured those same eyes with CATS, you not only saw a better efficacy from latanoprost, but a lower non-responder rate, making sense with what we know, which is that latanoprost is a good drug that works for most patients. Interestingly, timolol did not have this effect on hysteresis. It was measured in efficacy similarly with CATS and GAT, and the non-responder rate was similar with CATS or GAT. So it just kind of gets you a sense of the complexity of all this, but also of the value and the CATS way that it can kind of simplify management. You can just finally just pay attention to the pressure and have confidence. So we're looking to reduce IOP measurement errors related to mechanics, tear film, increase your confidence in these sort of out of the standard, you know, standard measurements for hysteresis, for thickness, and you know, yet at the same time, you don't have to do any new calculations because we fit on average as well with GAT. So CATS is equivalent, and this should improve patient care, give increased confidence, and kind of empower your ability to act on the numbers that you're seeing rather than have to second guess them.
Thanks, Nate. Well, great intro and follow through. And I want to echo what you said too about Sean and Dr. McCafferty's great work. I mean, this is really going to save a lot of eyes and a lot of vision, and you should be commended for that. And I was really anxious when I first purchased the technology to try it on a few of the patients. And the cases I chose were really some of the early patients. A lot of these are from my Indiana office, where I give credit all to also Dr. Austin Lifford, who I work with there, who heads up our glaucoma, where we have numerous cases, so we could kind of almost pick and choose from literally dozens that could play a role. And so let's take us through that, and we'll begin with a little bit of understanding CATS in clinical practice. What's great about the technology is you don't have to implement any new technology. You're really just replacing your GATS Prism with your CATS. There's no change in how you practice. There's really even not much change in how you line things up. There is none. All clinicians who've used Goldmann know how to use CATS. It's the same method of operation. You're looking for that same pattern of presentation. There's no change in how you disinfect it. So it's an easy way to implement a new technology. But I think you said it perfectly, Nate. It's that confidence in your IOP values that you achieve from having the CATS technology in clinical practice. So as you can see, the illumination, again, just like, I mean, this is like for anybody on this webinar, this is going to be obviously everything you already know, 45-degree angle of illumination, just like you would with your GATS tonometer. You've specifically, you set it up so it's piped into the prism just as you would. Decentrations indicated, you can tell by looking at the distorted mires. I like the fact, though, that with CATS, you're able to get this almost self-centration feature that guides that positioning by how the fullness or the roundness of the mires are. And you can pick it up very quickly to tell where, so I think that also adds to the integrity of the data that you find. It further contributes to the accuracy. Of course, that's the minor contributor. I think what Nate described and Sean described is really the big things, that you're accounting for central corneal thickness, you're accounting for hysteresis. But notice how that is another advantage to the accuracy that takes place. And I just find it easier to be able to assess the endpoint. So let me give you a couple of cases that I think will help put everything we talked about in perspective, because they really tie in beautifully. And what's interesting is Nate didn't get to see the cases when he was working on his presentation, or Sean, but everything he described pretty much lined up exactly with what we're going to discuss today. First case is a glaucoma suspect. I've been following this patient's been followed for some time. You know, amazingly, her Tmax, even over 5, I think these are 5 separate measurements, never exceeded 21, although in the left eye, that was our max level. She doesn't have any history of any issues related to it or along those lines. She's using artificial tears for some mild ocular surface issues. Best corrected has always been in the 20/20 range, but as Nate described, you know, the one potential, you know, making her glaucoma suspect immediately is her pachymetry, her corneal thinness at 510 and 500. And so as we talked about, this is the most recent visit, and I decided I would just, on the same day of having CATS tonometer, I would do my Goldmann first and then swap it out, just as easy as you saw in that example. So I started with the GAT, and you're seeing 19 and 20, very consistent with the traditionally all 5 measurements or 4 prior she's had. Then I put in the CATS tonometer. 1 minute later, 24 and 24. And of course, I pulled it away, went in again and lined it up, 24, 24. So it really quickly told me that this really is taking into account exactly what Nate described, the patients that are that outlier area where you're dealing with corneal thickness issues or thinner pachymetry, and those that may have a lower hysteresis. In my Lexington office, I have my aura there, so I check hysteresis. In my Indianapolis one, I need to get one there to check as well, but I have my CATS there. So I feel like I'm kind of covered, and I carry my CATS back and forth between the two. As you're looking at, obviously, optic nerve photos, you are seeing relative symmetry there. CDs, although it's hard to discern from that image, I apologize, not the best image, but they are really more around 0.6 by 0.7 in OD and around 0.6 by 0.65, a little less in that in OS. But nevertheless, very relatively symmetric, very reliable patient. We're getting good, signal strength, good reliability on her fields. And again, I put her as a suspect. I mean, really even following her retinal nerve fiber layer changes over the last few years, did not show anything too much above normal, but enough to kind of have me watching. Her original were around 87 on first visit. She's now showing up with about an 81. And again, that was over about a 2 to 3 year period. So not excessive, but not normal thinning levels, enough to wonder, but she never always stayed in that 19-20 range. Optic nerve wise, I never saw any higher risk of progression. Visual field testing continued to be fairly similar, very reliable, and although slight depression from a numeric standpoint, no significant changes even over that pattern indicating progression. But I always had her on that high suspect list because of her pachymetry, her family history, and just the potential that could play a role based on just having seen these patients. But without her having pressures high enough, it really brought me into the understanding that, what's the tipping point for when you want to treat these patients? And she's young enough that it really, would behoove us to treat her sooner than later? Is it just the thinning that we've seen from her retinal nerve fiber layers, changes, even though she still was in the green, quote unquote, she was seeing some changes in the retinal nerve fiber layer over that time. Very reliable glaucomatous visual field defects only. Would that indicate it, which she did not have? Is it the combination of the two, or do you rely specifically on elevated IOP levels? And of course, the answer, as we all know here, is it's all of those that come into play. But it's in these cases where this extra technology of CATS Prism plays such an important role, because it created the tipping point when I understood her pressures were truly 24 millimeters of mercury. And I was on the verge, just on a retinal nerve fiber layer changes, to pull the plug on and go ahead and start treating her topically with latanoprost or with a prostaglandin analog. But that was my convincing. And it's just, you feel so much more confident when you have that reliability of an accurate IOP. And that provided the key critical information to assess that patient and to begin her therapy. So very first case, first day, I changed my approach in managing that patient, and I feel more confident with that approach, as does the patient, who for years had, even in that time period, had always wondered, should we be starting? She's one of those more apprehensive patients. This really helped confirm we're on the right path. I'm going to give you another example here, but this time we're talking about a patient who's 75 who truly has advanced glaucoma, and that's where, these are the ones we all monitor closely. Her Tmax is over her history, so I don't want to I don't want you to think this is a recent Tmax. I'm just going back in her chart quite a few years. We did an express shunt at the time, 2017. We were doing CyPass, so that was also included at the time of her cataract surgery. We've had her on maximum therapeutics with latanoprost, brimonidine, and timolol, of course, being combination there. She's had, over the time, we had dorzolamide and notalcil allergy responses. And so we have tried numerous things to get her pressure down, but I've always felt like I had her in a good range. My target was in the low teens. Really, if I could get her around 12, 13, 11, I felt like that was going to keep any progression from being a factor just based on her history. She has relatively, slight thin, but no significant thinning in her pachymetry. And her vision is showing some effects, as you'll see from her testing here in a moment. But here's a perfect example again, where my confidence was wavering because I didn't know why she was progressing with pressures in my target range of 12 and 13. I've done a lot of things to get her to that level, and was to get our measurements and felt very good from a Goldmann perspective that we are where we need to be. And yet, as you see in her history, that was not the case from this glaucoma as it continued to progress. And in my mind, when I see that, I think, is this patient being adherent? Are they one of those patients who, kind of like when you go to the, I have a dentist friend nearby, and he says, yeah, people, start flossing the week before their exam. And of course, we know that because they're just the way the gums look inflamed. And he said, do they ever do that for glaucoma or other procedures? I said, I know there are patients who do, who like literally 2 weeks before they know their exam starts, they do. And so they had this hiatus of drops. And I didn't think this patient was that, but those things could be the case. It could also be that maybe we're losing the effect of the devices. I mean, we don't know as well the long term of that. I certainly, some of them like Hydrus and others seem to show good 4 or 5 year data, but CyPass, I don't have long-term data. Especially I'm wondering if perhaps that is what's changing. And ultimately, here I am with a new testing device with the CATS Tonometer, and that explains the progression at 14, 16. Again, optic nerve's not as well to see because of the slight tilt there, but she's, certainly a little much more advanced. You'd also see some, changes that are occurring towards the notching area in that superior zone and temporal. So let's go to the next slide. You could definitely see from GCC as well that, this patient is superior temporal thinning. You're getting overall good analysis, good signal that's coming into play, but a relative symmetry between the eyes, but obviously a much more advanced case. And what for me was fascinating is how she continued to progress, and yet I had her pressures, I thought, down to the 12 and 13 range. Her left eye, even though that does look like certainly advanced, and she's certainly more advanced glaucoma, no question, that left eye had actually been relatively stable for a period of time, even with those. But then I was starting to see over on the right, you could see, progression. That was not present over the last few visual fields, and it correlated obviously with the OCT. And the analysis continued to show this, and you can see there, possible progression even listed right there on our visual field testing. So finally, I was able to discern, the answer for this. very readily. And now, having this instrument, having CATS present early on helps me to really determine with confidence what the true IOP is. It's the way Nate described it. It's not so much that patient in the center, but it's those ones that have hysteresis that's low or that have corneal thinning or the post-LASIK, where it's really difficult to tell, with confidence what's going on. But it's also the progressing patient like this. I mean, was her IOP, it was not at target, because the post-surgical regression was occurring, but her IOP with GATS was showing at target. Her was it adherence? Is one of those patients like the dentist's office who starts using her drops when she realizes the exam's coming in. She didn't seem like that type of patient, but certainly I've seen progression in others like that. But ultimately, it was just the OS is underestimated with GAT and thus not at the target levels I had anticipated, and the data is showing progression being present. So we are seeing that now, and of course that was the eye with the 16 millimeter of mercury pressure. The other eye was reading 14, and the progression was present and consistent with the new accurate IOP because of CATS tonometry. What I love about the technology, you're gonna do a polling question here, is that right, Dave?
Whenever you're ready for me to cut in, Doc.
Let's hit it, and then we'll go over how similar it is to using GAT, which we started with.
So all three of our speakers tonight have talked about central corneal thickness and its effect on Goldmann measured IOP. So the question here is, do you believe that formulas that adjust Goldmann IOP are accurate? And you can vote on that question right now. And we got 100% no, 94% no, 95% no. So that's good. I think it's been a challenge over the years for a lot of the people who speak about these things to try to deprogram people from these corneal thickness adjustment algorithms. But it looks like the needle has finally been moved, gentlemen. Close that poll and back over to you, Dr. Karpecki.
Thanks, Dave. I'm glad to see those numbers, because I remember when we used to calculate changes, and it just never seemed to correlate, even intuitively, when we were monitoring patients who were progressing like these cases, and really helps us to understand. So in summary, IOP is still our greatest modifiable risk factor in the development progression of glaucoma, even with its faults and its, what it's measuring, and the fact it's, 0.29 pounds per square inch. But I think Nate said it perfectly. Small changes have a big effect on the nerve. It's extremely sensitive. So corneal biomechanical properties like central corneal thickness, corneal hysteresis, and applanation techniques, decentration, the tear film. And again, you get away from a lot of that as well with the CATS tonometer. But the bigger thing is that CCT and the hysteresis that does tend to throw the numbers off, as you saw in both these cases, a suspect case and an advanced glaucoma case that was progressing. They affect the IOP measurement accuracy. We do know center cornea is obviously play a role, as does hysteresis, but correcting for applanation tonometry with CATS is that with that very amazing technology, Sean. It really has made such a simple change. I just switch out my tonometer, and here I've got all this information that I never had before that I can rely on. It's less sensitive to biomechanical properties such as thickness and hysteresis. It's shown increased repeatability and accuracy compared to Goldmann applanation and intracameral pressure as per your study, Sean. And then the clinical observations demonstrate how clinically relevant this is and how that meaningful difference of the patient going from 12, 13 to now we know it was 14 and 16, and seeing that left eye progress really helps to understand the picture. It puts it all together. And one of the most difficult things sometimes in management of glaucoma is when you start getting variability amongst your measurements. And if you can eliminate that with something as simple as using the exact same method for measuring tonometry, but just swapping it out with the CATS, that becomes incredibly invaluable and gives you the confidence that what you're doing is spot on. So again, cleaning and disinfection, no difference. Now, I don't think a lot of us realize that to clean tonometers, there are steps that the FDA has dictated, that are recommended. And for, it's not alcohol cleaning. It really involves, Sidex, Prism in Sidex for a certain amount of time. If you were to read the Goldmann tonometry insert that kind of goes with it, it's exactly the same. So it certainly, is the same one. And the point is that just for completeness, this is a good way, especially in COVID era, to be able to keep that safe and how to maintain it long term. And the same disinfection and cleaning requirements exist for GATS as they do for CATS.
All right, so we get our final poll question of the evening here. And let's see if the presentations have had an effect tonight. So do you believe that errors in Goldmann IOP accuracy affect decision making, basically, is the question, and 100% believe that clinically relevant and important errors are present in Goldmann tonometry. So boy, the polling has really confirmed tonight that we've been making a difference over the years with changing hearts and minds about the accuracy of Goldmann tonometry. 20 years ago, if you suggested that Goldmann is not accurate, that was akin to blasphemy. But as Dr. Radcliffe said earlier, nothing disparaging about Dr. Goldmann, unbelievable contributions to ophthalmology, but time moves on and technology moves on. We have a bunch of great questions that have come in during the presentations tonight, so I'm just going to throw a few of them out there. Maybe I'll throw this one over to Dr. McCafferty. Sean, what is your opinion of the dynamic contour tonometer, and what would you use the correlation between CATS and the Pascal DCT?
The Pascal, I've used it many times, and it does reduce the corneal contribution. It's a little difficult to use, and if you've used one, you'll know this. And I think there's a certain reason why, and that's even with the PCT, they did not account for the tear film. And what you do is you get this adhesion of that cupped surface directly on the eye, and then there's a certain amount of force that's maintained on that. But you can actually pull this back and forth and get some variation on your measurement with the DCT. And furthermore, there's typically some bias in the DCT as well. I think that the way it was designed, you actually do on average measure a higher pressure with the DCT. And I think there's a few studies that have bore that out as well, that they did not fully go back and make it comparable to the GAT.
You're absolutely right about that. And when they designed that, they did it on a manometric pressure study. And like you found, Dr. McCafferty, they found that Goldmann underestimates the true intraocular pressure, and they went after measuring the true intraocular pressure. And as we've discussed here this evening, that can confuse clinicians as to how to interpret the values. And so I think that might have been one of the flaws of their decision making in that device. Another question that's come in, can you use it with a Perkins? I would assume yes.
Yes, as a matter of fact, that's what we did when we did the intracameral study. People were lying supine. We actually sat them upright, which is even more harrowing. But we also had them supine, and we used a Perkins to measure the pressure in that location as well. So yes, the weight differential is the same, so that you can put this in any orientation and be able to use it comparably with a Goldmann in a Perkins.
And then here's one I'll throw out to both Dr. Karpecki and Dr. Radcliffe. Ocular response analyzer versus CATS, or both? Do you need the extra piece of information, I'm assuming hysteresis, to manage glaucoma patients and make the right decisions?
I like having hysteresis. It gives me another, tipping point, so to speak, in terms of what's going on. Knowing that I have a lower measurement, certainly gives me, tells me I have to be a little more cautious. I still look at them slightly independent in terms of the IOP measuring for that, for hysteresis as a real key, numeric that I have to have, but also look at hysteresis as its own risk factor, just as I would look at central corneal thickness. So, and there are times, where it's been the other way around, where pressures and thickness kind of in the normal range, the patient's kind of on that borderline, but then I do my aura and hysteresis measures at 10.5, and I feel like, okay, we're going to continue to monitor this. A little more of that extra, sometimes just 1 or 2 extra data points is all you need in those borderline cases to help you make the right decision and follow them. So I'd love having both. In a perfect world, I would want to have both. But as I mentioned, I carry the CATS up to my Indiana office, and I keep it in my Kentucky. I only have my aura in my Kentucky office. So I do manage well. The cases I gave you were both with just CATS. That's why you didn't see hysteresis listed like they would be from the Lexington office, but I do feel a little more confidence having both measurements.
And I'll piggyback there. I agree with everything you said. It needs to be said that you can afford more CATS than auras because it's relatively inexpensive, and that's my hope for this technology, is that The ease of getting this into practices, you could start with one and then get them in all your lanes once you feel comfortable, is going to allow the technology. You know, Dave, you and I have been working, and you know, Paul, I know as well, on hysteresis and aura for a decade. It's slow growing because there's a capital expense, and each practice is a little different. CATS can grow much more quickly, and it can be adopted in a day. You can travel with your CATS, but more importantly, it's financially feasible to just get it for multiple machines. One thing, just to give you an example where I love hysteresis, having a hysteresis of 12 or 13 is a strong indicator that you will not progress. And, you know, you can get a hint at that hysteresis with your CATS-GAT comparison, but there's something nice about having the number you can write down and put your bet on that. At the end of the day, though, when we say hysteresis measures the risk factor, but it's also a correction factor, CATS is taking care of that correction factor part of it, and knowing the hysteresis variable gives you the risk assessment. So I like them both, but I would really like to see CATS grow, and I think it has the potential to in a way that the aura, you know, has been more slow and steady.
You know, I would echo that as well. I think that if you look at glaucoma, I tell my patients is this preponderance of evidence, and the more evidence you have, the better off you are. So if you have this extra data point, such as corneal hysteresis, and I use it exclusively, I use it pretty much on all of my patients regularly. And it gives me one extra data point that I can say, you know what, your corneal hysteresis is 13. I just, you know, it gives me an extra margin of comfort, saying, oh, these other things, they look that way, but, you know, I actually feel a little bit more comfortable saying we're holding off on doing anything at this point in time.
A couple more questions here before we wrap things up for the evening. One's just kind of a general question. Maybe, Sean, you're a technology guy. Can you comment on OCT versus ultrasound pachymetry for accuracy?
Well, I mean, the OCT is much more accurate. As long as the operator's using it properly. On average, you're going to find that that if you're looking for central corneal thickness, then the OCT, you might have a little bit of variability. If you're looking for the thinnest part of the cornea, you're definitely going to measure with the OCT much more accurately. On average, I'd say when I measure both of those, I'm usually about 15 microns thinner measuring by OCT than I am by a good pachymetry measurement centrally, because it's never really exactly in the center. It's always a little bit off, and you're usually getting a little bit thicker cornea involved with the pachymeter.
Last question here is, since Goldmann is the standard, do you have to do both? What are your comments on that? Do you have to switch the prism back and forth between the two, or do you just stick with the CATS?
Just stick with the CATS. That really gives you, that accounts, because if you have a normal corneal thickness, kind of that average hysteresis, you know, I did that at the beginning. You saw my cases. Those were patients where, just because I knew I would have some cases for tonight, I wanted to be able to kind of show what the Goldmann was that day. And it wasn't meant to say do both. It was just to kind of give me another data point with Goldmann, the fifth one in one case, you know, and maybe a third one in the second case. But it was another way to show that, you know, what a difference was even on that day, just not from a historic perspective. But at this point, we pretty much have replaced all Goldmann with CATS, and that's why I need to get one now for my Lexington office as well, so I don't even have, in case I forget to bring it back, you know, and in each lane, it really, because now you're accounting for all the averages for Goldmann kind of did, but now for the outliers that are so critical, and there's so many of them. So that's the great thing about it. You don't have to learn anything new. You don't have to figure out how to interpret it. You don't have to measure it differently. You just truly just take the Goldmann out. Now you have a much more accurate tonometry tip known as the CATS, and that's all that I would rely on today.
So I guess I'll wrap up this final summary slide here, that I think what we've heard this evening from our speakers is that CATS reduces IOP measurement errors related to thickness, biomechanics, and tear film, and but it does so in a manner that enables you to maintain long-standing benchmarks of IOP standards, 15 average, 21 high, those sorts of things. You can just have more confidence in the Goldmann numbers you're getting with this prism because it ignores those artifacts. So it gives you increased confidence in thick and thin corneas, corneas with high astigmatism, and when corneal biomechanics are different from average, and that includes in situations when the cornea has been surgically modified, such as in LASIK or PRK, or in incidences where you have pathology like keratoconus or Fuchs, for example, that may modify corneal biomechanics as part of the disease process. And it's inexpensive, as Dr. Radcliffe hinted at, and easily adopted into your clinical practice, as Dr. Karpecki said. So this isn't a selling event here, but it is really hardly any more expensive than a standard Goldmann prism. You can visit the Reichert website and find your local dealer, or you can buy them directly from Reichert if you're interested in trying one out. So that's it for this evening. You will receive a survey from us in your email. Thank you for registering and taking time to spend with us this evening. If you didn't catch any of our previous webinars here in our Reichert Remote Learning series this spring, we did 3 or 4 other webinars in the past number of weeks. You can go to our website, or you can go to passionateabouteyecare.com/remote learning, and you can find links to those videos and watch and learn some more. So I look forward to seeing everybody here in person, hopefully later in the year. But between now and then, stay well, and thank you again for joining us. Good night, everybody.
Thank you.
Thank you.
Thank you all. Great night.